Hi everyone, this is a longer version of the presentation Can Sexual Health Clinicians Be Replaced by Robots? Which I presented at BASH, the British Association of Sexual Health and HIV's annual conference in 2023. Treat this as a podcast. Feel free to minimize this video and carry on working and flick back again when there's something you want to see. Today I'm going to ask, can sexual health clinicians be replaced by robots? Don't worry. This isn't a dystopian vision of the future, it's an assessment of where AI currently is. I'm Howard Gies, and I'm the Data and Systems Manager for Sexual Health Services at Nottingham University Hospitals. I've been working in sexual health since 2012, and my long-term aims to get clinicians back to clinical work and automate all the admin tasks that they have taken on. This study is more specifically the look into the utility of AI platforms to give sexual health advice. It was carried out with the help and input from Ruth, Ellen, Rebecca, Chi-Chi, Lee and me. I have no conflicts of interest to declare in relation to this study. Let's bring it back to the question. It's June 2023. Can sexual health clinicians be replaced by robots? Yes. Nobody else wanted to tell you that. Short video. Thanks for watching. No, I won't leave it there. Let's open this up and dig a bit deeper. We all use Google. Well, apart from 3% of you might use Bing, but we use Google to find our information, and our patients currently head to Google for their information. But AI is new, and our patients are going to start using AI as their source of information. So we wanted to know what AI could do. Artificial intelligence is not currently possible. Let's not get confused between AI and artificial intelligence. In 1950, Alan Turing created a test for artificial intelligence. Very simply, we should be unable to determine if we're chatting with a computer or a real person. This test hasn't been met yet. The term AI is a current buzzword used by marketing departments of technology companies. With so many press releases, newspapers are just full of buzzwords about AI. AI doesn't truly understand or know information as we do. It can simulate a form of intelligence that can start to appear convincingly human-like. For this study, we used OpenAI's ChatGPT-4. For this video, when I use AI, I mean the ChatGPT-4 machine learning natural language processing model. Again, back to the question, can sexual health clinicians be replaced by robots? Our aim was to answer just two questions. First question, is AI wrong? Is it safe? Our second question is, how good is AI? Is it as good as a nurse, a doctor? So how do we conduct this study? We didn't mention AI. We didn't want to influence any staff attitudes. And we came up with 5 scenario-based questions relating to PrEP, STI and contraception. We requested short 150-word responses to keep the answers relatively comparable in length, and we said they were going to be for a magazine's letters page. Once we'd had all the responses, I mixed them up and anonymised them, and that ensured a blind evaluation by a clinical head of service. Note, this wasn't a test of how well or badly our clinical team did. Their answers are included as a control and as a scale which we could rank AI against. So the questions. 2 of the initial set of questions were too simple. We rejected them and came up with new ones. We don't want to make it too easy for AI, so these are not all straightforward queries. In fact, we deliberately chose complex compound questions that didn't have readily available answers. AI couldn't just copy and paste from the internet. Question number 1. I was diagnosed with HPV 3 years ago. I have no current symptoms. Is there a risk of me passing it on to my new partner? Question 2. I'm taking lamotrigine for epilepsy. What contraception can I use? Question number 3. I missed my dose of HIV pre-exposure prophylaxis for the last 2 days and had unprotected sex today. Do I need to take HIV post-exposure prophylaxis? Question 4. I'm getting side effects with my HIV pre-exposure prophylaxis. I last had unprotected sex yesterday. Is it safe to stop my HIV pre-exposure prophylaxis? And question 5. I've had a small intestinal resection. Is it safe to continue on combined hormonal contraceptive pill? Okay, well, let's take a look at our baseline, the answers we got back from our clinical staff. Here are 3 answers to the first question. I've picked one to read, but that doesn't make it the best answer, just the luckiest. This is a question about HPV. If you have no symptoms of genital warts, nor had them recently, then the risk of passing on the virus is very low. The reasons is that we cannot say no risk, is that many of us may carry different types of the virus and do not know we have it. If your partner displays symptoms of the virus, warts, then they may have had the virus some time and not necessarily caught it from you. Question number 2 was about lamotrigine for epilepsy. I thought it'd be good to show the range of answers we received. We asked some magazine letter-page replies of around 150 words. Here are 2 extremes. I'll read the shorter one. Injection or coils are ideally the best. However, other methods are available and can be used. Regimes or doses of the methods of lamotrigine may need to be altered. Question number 3 was about a missed dose of PrEP. These questions were complex and designed to stretch AI. That also means that they were going to stretch some of our staff. Again, I'm not going to read the best answer. These control answers are just so we can rank AI. It depends on the type of sex you've had. GBMSM and trans women for receptive anal sex, as long as you have had 4 tablets in the last 7 days, you will not need PEP. Frontal, neovaginal sex, need PEP in more than 48 hours after last dose. Question number 4 was about a side effect with PrEP. Again, I've picked a representative answer to read. To be protected against HIV with PrEP, you need to continue taking 1 tablet every 24 hours until it's been 48 hours since the last unprotected sex. If you are experiencing severe side effects, it'd be advised to discuss with a sexual health professional for them to assess the side effects and advise if it is safe to continue the PrEP for 48 hours. And then question number 5 was about the small intestinal resection. For this question, I'll switch back to comparing and contrasting between the longest and the shortest answers, but this time I'll read out the longest. No, it is not safe to continue combined hormonal contraceptive pill if you have had a small bowel resection and malabsorption. The effectiveness of combined hormonal contraceptive pill is reduced in Crohn's disease or malabsorption due to severe small bowel disease or resection, or in people who have vomited or severe diarrhea for more than 24 hours. This is because combined hormonal contraception will be poorly absorbed, as most drugs taken by mouth are absorbed through the small intestine, which has now been removed. It is recommended that the combined hormonal contraceptive pill should be stopped at least 4 weeks before the surgery and alternative contraception provided. Other contraception options such as the patch, depot injections, implants or the coils, hormonal and copper coils, should be considered as their efficiency is not affected by small intestinal resection. Right, now we've got our baseline. It's something to compare AI to. Let's take a look at the answers which AI gave. AI's answer to question number 1 about HPV. HPV, human papillomavirus, is a common sexually transmitted infection. While your diagnosis was 3 years ago and you have no current symptoms, there is still a possibility of transmitting the virus to your new partner. The body can sometimes clear the virus on its own, but the absence of symptoms does not guarantee that it has been eliminated. To reduce the risk of transmission, practice safe sex by using condoms and discuss your HPV status with your partner. It's also important to encourage your partner to get the HPV vaccine if they haven't already, as it can protect against certain strains of the virus. Regular checkups can help you monitor your HPV status and maintain your sexual health. So AI knows what HPV is, first line, and it's already picked it out and defined what we're talking about. I'm not clinical, so I'm not going to put any clinical judgment on these answers. That will come later in this video. Question number 2 was about lamotrigine for epilepsy. This is AI's answer. Lamotrigine is a medicine for epilepsy that can change how some birth control methods work. Birth control pills with 2 hormones may not work well with lamotrigine. There are safer options like birth control with only 1 hormone. These include the mini pill, birth control shots and hormone coil. Barrier methods like condoms and caps can also be used without problems. It's important to talk to a healthcare professional about your situation. They can help you find the best birth control for your needs, consider your epilepsy medicine and personal choices. AI's initial answer to this question was pitched just a little higher than I was expecting, so I told it. I said, magazine readers may struggle with some of these long words. Can you rewrite that answer to be easier to understand? That was its rewritten answer. Question number 3 was about a missed dose of pre-exposure prophylaxis. This is AI's answer. If you missed your HIV pre-exposure prophylaxis, PrEP, dose for 2 days and had unprotected sex, there may be a risk of HIV infection. Post-exposure prophylaxis, PEP, can be taken to reduce this risk. PEP is most effective when started as soon as possible, ideally within 72 hours of exposure. It's important to talk with a healthcare professional immediately to discuss your situation and decide if PEP is right for you. Remember, using condoms can lower the risk of HIV and other sexually transmitted infections. Talk to your healthcare provider about ways to make sure taking PrEP regularly to keep yourself protected. Look at that, AI knows its PrEP from its PEP and how to capitalise them. Question number 4 was the side effects with PrEP. Let's have a look at AI's answer. If you're having side effects from your HIV pre-exposure prophylaxis, PrEP, it's important to talk with your clinic before stopping the medication. Stopping PrEP suddenly can increase your risk of HIV infection, especially after recent unprotected sex. A doctor can help you understand your side effects and may adjust your treatment plan or recommend a different type of PrEP. In the meantime, continue using condoms to protect yourself and your partner from HIV and other sexually transmitted infections. Always talk to a healthcare professional before making changes to your medication and keep them informed about your concerns and experiences. Okay, time for me to come clean. These aren't exactly the answers which AI gave. AI is very cautious and very American. Every answer had talk to your doctor or healthcare physician, which I've tweaked to say a doctor or healthcare professional. It was just so it didn't get spotted when our head of the service reviewed it. AI also writes disclaimers about not being a source of clinical information, and I've trimmed that off the bottom for each answer. And question number 5 was about a small intestinal resection. AI's answer. After a small intestinal resection, the combined hormonal contraceptive pill may not be as effective. The surgery can affect your body's ability to absorb the hormones from the pill, which could make it less reliable for preventing pregnancy. It's generally safe to continue using the combined pill after the surgery, but you might want to consider using additional protection, like condoms, to ensure you're protected against pregnancy. However, it's still a good idea to discuss your situation with a healthcare professional to confirm that combined pill remains a suitable option for you. Other contraceptive methods, like progesterone-only pills, contraceptive implant injections or IUDs, may be a reliable alternative to consider after a small intestinal resection. I've been told this is incorrect, possibly. Well, actually, best guidance in the UK at the moment. We think that AI is following guidance in place outside of the UK. Now you've seen AI's answers. How far away does that dystopian future look? All answers had their authors removed and then saved as text files, with each answer given a random letter from A to E. This means our clinical head of service was completely blinded to whose answers was whose. Now we can take a look at some of the feedback from that clinical review. Back to our first question, is AI wrong? The AI responses we received were generally clinically appropriate, so not wrong. That's a big step for AI. But not wrong is subjective. There was an instance where AI's advice didn't align perfectly with UK guidance on a complex contraception, but it followed similar guidelines used in other parts of the world, and it did signpost to specialist advice. Second question, how good is AI? Okay, AI failed a Turing test. That isn't bad news. We could identify AI's answers, but partly because they were suitably pitched and well structured. The clinicians' answers were shorter and occasionally contained incorrect information. Now, I've seen Daisy Christodoulou speak about comparative judgment, so it's no surprise that we mark these answers by ranking them. Every A answer was in the top 2 and was often the top answer. Also, AI delivered its responses almost immediately, in less than a minute, compared to clinicians' average of 7 minutes per answer. AI was also immediately available, and it didn't need to have me sending it a chase email out over the course of the week for it to respond. How? In 1962, Arthur C. Clarke wrote, "Any sufficiently advanced technology is indistinguishable from magic." In reality, AI is still a complex and sophisticated type of predictive text. I've got a graph here because it wouldn't be much of a presentation to bash if there isn't a graph. The point to take away here is that AI will always give you the most popular, the normal, the average. That doesn't mean it's right. We did get answers that weren't quite right in the UK. So data sets, let's have a look at the AI and its bias. If we ask questions about sexual health in Africa, then we might be getting a very different set of answers. However, AI is clever. It does know it has a bias and it can adapt. What do we know about AI's data sets usage? Well, very little. This is a scored indicator, but it shows lots of companies using big data sets which we know very little about. I can't give you better answers about AI's data sets. Let's get back on track. Can sexual health clinicians be replaced by robots? Where does this study leave us? It's okay, it's not wrong. Your jobs are probably safer this year. There's still a need for that human touch. AI generally delivered accurate and safe answers quickly. How good is AI? Well, in our PrEP and STI scenarios, AI provided more detailed responses than humans and included more health promotional material. However, in the more complex contraception scenarios, some human answers were rated higher than those from AI. What now for AI in clinical practice? Well, despite the promising results, AI cannot yet take the place of a clinical discussion with an experienced professional. AI could serve as a valuable supportive tool, supplementing your work and offering out-of-hours advice. Incorporating AI into one national patient-facing website could be beneficial. A national sexual health advice platform powered by AI could provide quality advice around the clock. What now for AI in administrative tasks? AI is not just ready, but it's already in use. In our sexual health service in Nottingham, I've been using AI daily for over 2 months. Mostly for our back office tasks. It's performing well. Its proficiency is that of a university graduate apprentice. Now, I'm recording this before the BASH conference, so I don't know what questions are going to be asked. Instead, I've asked AI what it thinks the audience will ask. Could AI contribute to misinformation if it fails to align with local guidelines? Worldwide guidelines do differ, but I wouldn't call following a different guideline in sexual health misinformation. Instead, we need to focus AI on following our guidelines. In this study, I should have told ChatGPT to always and only follow BASH guidelines. I didn't, so AI took a tangent off to more popular guidelines. How can patient privacy and data security be ensured when using AI? Simple, it can't. We can't trust any tech company with sexual health data. There is no right to be forgotten with big data. Just this week, tweets and posts of Reddit that were deleted years ago have come back. We could host our own AI instance. We could use other AI instances but never give out identifiable information. Next question. Could the use of AI lead to a de-skilling of clinicians? What is de-skilling? Should this be skills for the 21st century? The calculator would lead to nobody being able to do maths. So, Professor Arnold Pearce from the Royal Institute of Technology in Stockholm says that we need to, and should have been before, I'm paraphrasing, be marking students' processes rather than their completed articles. Do we care how a clinician got to the right answer if they do get to the right answer? Maybe we'll end up with a larger skills divide. How would the AI handle ambiguous or unclear queries from patients? AI is not very good at saying it doesn't know or it doesn't understand. However, it does have infinite patience, vast knowledge and understanding of almost every language. I suspect that if it was ambiguous for AI and it didn't clarify, it would already have exceeded a human clinician. What is the potential impact on health disparities with the use of AI in healthcare? Great question. AI is a new technology. That means anyone who isn't using technology is just going to get left further behind. How does a patient book into our clinic if they don't have access to the internet? Will walking clinics become a pauper's clinic used by Luddites and technophobes? Probably not. I can't see us ever having clinics with 0 humans. There's likely to be a receptionist, even if they're balancing lots of tasks and new tasks. I think if we keep an eye on how we use tech to engage with patients, we should be able to minimise health disparities by freeing up staff time to focus on people. But it's a good question. How does AI handle rapidly evolving medical guidelines in the light of new research or pandemics? We've crossed the boundary of the AI revolution. AI was populated with data from the internet before 2023. By 2024, 50% of the content on the internet will have been created by or with the help of AI. By 2025, that'll be most content. If we feed that back into AI, it will just reinforce itself, so we can't. We now have a pre-AI and a post-AI split. Good AI datasets will be updated from trusted sources such as the NHS website. Bad news, the NHS website's already being populated using ChatGPT. How do we mitigate the risk of AI developing or amplifying bias in healthcare advice? Computer says no. Very quickly, clinicians will get into the habit that AI is right. And it is. Well, it's not wrong, but it's making the best decision on the information available to it at the time. And that time was before 2023. If we now find that our bias threw out some data, some assumptions that has then been built into AI, it's going to be hard to unpick. I don't know how we tell AI that the facts have changed. How does the use of AI in healthcare align with the principles of informed consent? I read this question when putting these slides together, and I really didn't have an idea. Since then, I thought on it a little. Seeing this again now, my mind's blank. I still don't have an answer. Do our patients expect and understand that we use Google? When we do we explain that to them? Is Google part of our informed consent? Is AI the next Google? So do we just trudge along until it's mainstream and that way everyone would just assume that we've been using AI? What do the BASH guidelines on using AI in sexual health say? Let's follow them. How can we ensure transparency in AI algorithms used in healthcare? We can't. It's never going to happen. If we can say we use AI from company X or Institute Y, but those organisations aren't going to share their algorithms with us, welcome to dystopia. What measures are in place to ensure accountability in the case of an AI error? Ooh, who's accountable? That's not quite the question, but still. This is the same thought process as driverless cars. Who's accountable when your automated Tesla crashes? Tesla? You? The government who signed it off as safe to use? I'm going to say that providers are accountable to give out the best information they can. That's AI or human. It'll be interesting to see how we start to assign, I'm not saying blame, accountability, when we investigate an incident and the entire AI conversation is transcribed into the patient's notes. The measure in place is a full transcript in the patient's notes. Well, that brings us to the end. I'm Howard Gies. Hopefully you've watched me in person at BASH, but I know I'm on at 8 AM, so there's every chance you're still eating your breakfast. If this video was useful, then let me know. I'm on Twitter. I work at Nottingham. If you work in sexual health, you'll be able to find me. Thank you for watching.